Good morning, everybody. Thank you so much for giving me the opportunity to come speak with you this morning. I see a lot of familiar faces out there, so it's nice to see you again. And to those of you who I haven't met, I hope to do so in the future at some way through the Leukodystrophy Clinic. As Dr. Vandiver said, my name is Christina Minkoff, and I'm a speech-language pathologist here at CHOP. My goals for the next 15 or so minutes are to talk with you a little bit about what a speech-language pathologist does in general, but more specifically in the context of our center here, since you may have an opportunity to meet with me or one of my speech pathology colleagues during one of your future visits to the clinic. Generally speaking, a speech-language pathologist has a fairly broad role. You may know of some speech-language pathologists in the school setting that are working on things like articulation problems or difficulties with understanding what a child has read, so ability to read a passage and understand that passage. You may also know a speech-language pathologist who works with a child who may have difficulty with communication, who does not use speech as their primary modality of communication. Speech-language pathologists also work on a variety of oral motor or oral feeding-related issues. That's really our primary role within the Leukodystrophy Center. Here at CHOP, speech-language pathologists are involved in a number of clinics to manage both communication and feeding-related issues. There are a number of them listed here, but certainly the most important is the one here at the bottom, the Leukodystrophy Center. Generally speaking, in a visit through the Leukodystrophy Center, we have really two primary goals. One is to screen your child's communication skills to help get a better understanding of how they're communicating, and if they're experiencing challenges with communication, what might be the appropriate intervention or next step or referral. Our second goal, when it's appropriate, is to evaluate how your child is doing with any oral feeding that they might be doing. As many of you may know from your own experiences, oral feeding can be highly variable and can be significantly challenging from year to year, month to month, day to day, and then even across a day, where you might have situations where you say, my child really feeds with significant difficulty at nighttime, but breakfast is a whole different story. It's a good feeding experience for my child. And so we're involved in trying to help get an understanding of that through the clinic. Most children with the leukodystrophies that we're seeing in clinic have some form of communication difficulty, whether it's a receptive or an expressive communication difficulty. I think that generally speaking, the best way to really get a full assessment of how a child is functioning with their speech and language skills is really with a more comprehensive speech and language visit. And the clinic setting typically is not the best place to do that. We want children to be well rested and to be able to really focus on the assessment itself. So we do not perform comprehensive speech and language evaluations within the clinic. When families are looking for a more comprehensive speech and language evaluation to assess communication abilities, even in children who are not using speech to communicate, we make recommendations to refer that child and can oftentimes help with an expedited appointment to our Center for Childhood Communication for a more complete evaluation. Along those same lines, for some children, they may be appropriate for a more intensive augmentative and alternative communication evaluation. We do have a program here that offers augmentative communication evaluations and subsequent therapy. So when that's appropriate, rather than completing that very comprehensive assessment within the context of clinic, it's really more appropriate to refer you to a speech-language pathologist that can support you with that. And so during the visit, we are screening communication. We're checking in with families on what services might already be in place, and we're helping to direct you to the most appropriate services that may be available either here in the Philadelphia area or at CHOP, or perhaps even closer to home. We do not see all patients who come through the Leukodystrophy Center. We primarily are seeing patients for whom there is a question or a concern of how the patient or the child is eating by mouth. As I said before, this can be something that really can be pretty rapidly changing. You may go through phases where oral feeding feels like it's going really well and you feel really comfortable and in control of where it's at, and then other times where it might feel like it's changing and you're not quite sure how to handle it. So our role in this clinic is to try to help understand where is oral feeding right now, how do we help make the best recommendations and plan for what's going on right now, and how do we ensure that you have the best resources available to help you manage your child's feeding closer to home or here in the Philadelphia area if you are here. One way that we try to do that is by completing a bedside evaluation during the visit itself. Really simply put, the bedside evaluation is an assessment of your child's eating by watching them eat. So if you say, well, my child only takes purees, then we'd like to see your child take those purees. If you say, he likes these crunchy solids, but I'd really like him to be taking harder to chew solids, then we're going to try to evaluate that. In a bedside clinical feeding evaluation, we are offering consistencies, and then we're assessing oral motor skills and swallow function and safety with the textures that your child may be taking or with the textures that you're wondering if it might be appropriate for them to take. What we mean by this assessment of oral motor skills, we're going to look at the way that your child is chewing when they're managing solids. So when we start to learn to chew, we don't suddenly just have mature chewing right from the beginning. It's a process to develop mature chewing, and we actually go through a number of stages of chewing before getting to that mature chewing that we see in many adults. And so one thing that we're looking at when we're watching your child chew is what stage of chewing do they seem to be at? How do they seem to be managing the solids? So this is not your child is chewing well or your child is not chewing well. It's really more comprehensive than that. We're looking at what are they doing with their tongue? What are they doing with their jaw? And then to take that a step further, what are they doing with their tongue and jaw during the first couple of bites? And then what about 20 minutes later after they've been eating for a little while? Is there a component of fatigue? Does their chewing change over time? The reason why all of that matters is because it helps us try to come up with and create the most appropriate recommendations for your child, considering where their skills are at during a feeding. You may, if you've ever had one of these done, you may see a speech-language pathologist using a stethoscope on your child's neck. What we're doing is listening using surgical auscultation to the way that the swallow sounds and to whether or not your child may be experiencing congestion or a junky quality of their breathing while they're chewing and swallowing. We may also try some different strategies during the clinical feeding assessment, and I'm going to get into some of those strategies here in the next few slides. Generally speaking, the bedside feeding evaluation is a really nice way to get a look at feeding, and it's not that invasive. It's really just us sitting together watching feeding. There are some limitations to the bedside feeding evaluation, though. Really, the most common limitation is that sometimes kids just don't feel like eating. And that happens for everybody. Sometimes they don't really want to participate. They may not be hungry. They may have just had a feeding through their G-tube. They may have already eaten a large breakfast and don't really feel like eating while we're in the room. So assessing feeding clinically, actually seeing eating is a big part of that. Sometimes also the child's ability to follow directions or understand commands can impact our ability to complete this type of an evaluation. So for example, one strategy for feeding that we might suggest would be something like taking another swallow or tucking your chin down during a swallow. So for some children, these are very difficult commands to follow from a motor perspective, also from just a cognitive perspective. Their ability to complete those directions may be difficult. And so all of that's taken into consideration. During the clinical feeding evaluation, we're looking for certain things in children that might suggest to us that something else could be going on during their feeding. So when we think about feeding and swallowing, we think about a couple of different phases to the swallow. The first phase is called the oral phase. That's sort of the best way that I can describe it is like anything that happens in the mouth is part of the oral phase. So chewing is part of the oral phase. Sipping from a straw is part of the oral phase. Using your lips to strip a puree consistency off of a spoon, that's part of the oral phase of the swallow. The way that when you take a bite or a sip of food, you move it back in your mouth using your tongue, that's part of the oral phase of the swallow. The next phase of the swallow is called the pharyngeal phase. And the way that I think about this is it's sort of like your brain takes over and it controls the rest of the swallow. That happens when foods get to the base of the tongue. So we don't really have control over food anymore after it really gets to the very back part of our tongue. Then our brain takes over and the pharyngeal part of the swallow, or really like the throat part of the swallow, starts to happen. The things that you see up here are signs that we sometimes see in children that suggest there may be a problem in this pharyngeal phase of the swallow. So when we're completing that bedside clinical assessment, we're looking for some of these things. We're listening for some of these things. And most importantly, we're asking the experts, which are all of you, how does your child do with eating? Do you notice any of these things in their feeding? And sometimes parents will sort of say, like, well, we don't see anything like that. We don't want a G-tube, or we don't want a swallow study. Or in this clinic, I can tell you, that's not really why we're asking those questions. Our goal isn't to push you toward a feeding tube there isn't some sort of ulterior motive that we have to try to get you to something. We're really just trying to better understand what's the picture here. How is your child doing with eating? Because there are lots of things that we can do to make eating more comfortable and safe for children without exploring those other measures. And sometimes those measures are really appropriate and important. But there are a lot of things that we can try to do when we have a clear picture of what's really going on. In infants, some of those strategies that we can use really involve changing the flow of the liquid when the child is drinking. So changing the flow of the nipple that they're using. I know that seems like such a tiny little thing, but the holes in those nipples that we buy in the store for bottle feeding, they really vary pretty widely. A lot of the research in the field of speech-language pathology around this suggests that we're seeing pretty substantial differences in how fast the rate of the fluid, milk or formula or water flows out of the nipple tip based on the size of that hole. So changing the flow of the fluid by changing the nipple. Also, implementing pacing is a really appropriate strategy for a lot of patients who may be overwhelmed by the flow of the fluid and really need to take a break and get some breaths in. When you think about sucking from a bottle, it involves such a complex, organized sequence of movements with suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. One little slip up in that process can really cause a lot of problems in swallowing, as some of you may know. So the kinds of strategies that we suggest for infants involve modifying the nipple flow rate, modifying the position that the child is in when they're feeding, changing the viscosity of the fluid by thickening it. For older children, I'm going to skip over this slide because I think we've already addressed this. For older children, we really think about, what kind of positioning is the child in for feeding? Is it as optimal as possible, or can we use some support from our PT and OT colleagues around making sure that your child is positioned as well as possible for feeding? Sometimes alternating liquids and solids, modification in the way that the head is actually positioned during the swallow can have significant impact on the feeding. We learn why these strategies are appropriate and which ones to choose based on what we're seeing in that clinical feeding evaluation. So it may not seem like a lot when we're watching your child eat, but while we're watching them eat, we're really trying to think about, okay, what kinds of things does it seem like would be beneficial or not beneficial for this child? Sometimes making the bolus size smaller or creating a rest period during the meal is helpful. Removing distractions, you may have the experience with your child where they sort of stuff everything into their mouth because they're not really focused on the feeding, and now you have a mouth that's very full of food and the child is then sort of at risk for choking. So we look at all of these things while your child is eating, and we know that clinical assessment in the office when you come to visit the Leukodystrophy Center may not be the best assessment. So we always ask, how close is this in terms of representing your child's feeding skills? Are we close, or would you say that this is not a good representation of how you see feeding at home? Thickening is something that is suggested as a recommendation for some children, not all children. The reason why thickening is utilized is because oftentimes making the consistency of liquid thicker can be helpful for a child in terms of helping them during that pharyngeal part of the swallow protect their airway when they're swallowing. It slows the fluid down. And if you think about how slippery, kind of for lack of a better word, but sort of how slippery and messy something like water can get, and you compare that to like a drinkable yogurt consistency where it's more likely to stay sort of cohesive. If you think about that bolus moving through the throat, in a lot of cases, that sort of yogurty type consistency is going to stay more cohesive and maybe less likely to have a problem in that pharyngeal part of the swallow. That's not the case for all children. In fact, for some children, thickening liquids is absolutely not the way you would want to go. Because if they have some weakness in their throat, then that thicker consistency could be more likely to sort of stick to the walls of your throat and create some residue or sort of leftover stuff after the swallow has already happened. So really thinking about what are the right type of recommendations for this child based on their strength, the way that they're feeding, the strength of their swallow. All of those things are things that we consider when we make recommendations. There are lots of different thickeners out there. And in fact, a lot of families elect not to use a commercially available thicker and instead to maybe consider whether or not it would be appropriate to just use things that you find in your home, like applesauce or pudding or rice cereal or stage 2 baby food as a thickening agent. In cases when thickening is used, it's significantly important to work with a nutritionist because when we start adding all of these things to your child's liquids, especially formula, water, juice, it can really change the caloric makeup of what they're getting in a day. So it's really important that you don't try this on your own and that you really work closely with a nutritionist and that we have a really clear plan for, is thickening going to be a long-term solution for managing a swallowing problem, or is it something that we're just using for a short period of time? What are the recipes involved in thickening? I've worked with a lot of patients where this has been a really successful recommendation, but it's one that I think works best when you have the support of the whole team. Has anybody here ever been involved in a swallowing study? A couple of hands? Yeah. If you haven't been involved in it, you maybe have heard about it. I want to spend just a few minutes talking about it because speech pathologists are often involved in swallow studies. So when we talk about swallow study, there are really two different kinds of swallowing studies. They are the video fluoroscopic swallow study, or the VFSS, and the fiber optic endoscopic evaluation or swallowing or FEES. We're not really going to spend a lot of time on the FEES today. I'm happy to answer more questions about it if anyone has them, but briefly speaking, the FEES is something that's done in conjunction with an ENT, and it occurs when, here on this left image would be a good place to look, a very small camera is sort of fed up the nasal cavity there, and it sort of drops down into this nasopharynx and oropharynx area, and we leave the camera over that space, and your child eats with that camera in place. So really comfortable, as I'm sure you can all imagine. But it gives us a bird's eye view of what's going on when your child is swallowing. It's not a test for everyone, but when we talk about swallow studies, this is one of the studies that we're talking about. Much more commonly used is the video fluoroscopic swallow study. And actually the picture on the right here, I'm going to step away from the microphone and just point to what I'm showing, shows a really nice example of what aspiration actually is and what we're talking about when we talk about aspiration. So you can see the black stuff here is barium that the child has swallowed, or in this case that an adult has swallowed. And that barium has come down into this passageway here that we call the vallecula, and then it's passed below the level of the vocal cords, which are here, and is being aspirated. This material here is in the trachea, and that trachea is the entranceway into the lungs. The VFSS goes by some other names that you might have heard a doctor refer to. The modified barium swallow study is the same thing. The barium swallow with speech, same thing. So these names all refer to the same type of test. We do the test in radiology, and we try as much as possible to put the patient in as typical a feeding position as possible. Oh, thank you so much. We try as much as possible to put the patient in a typical feeding position. The child has to drink barium for this test. Sometimes that barium can be mixed into foods that your child might like. So for example, if your child really likes to eat pudding, sometimes we can mix the barium into the pudding and it may be more appealing. My experience with this study is that smaller children under the age of 4 tend to do better on this test. As children get older, and then certainly adults, tend to have a harder time drinking the barium. The taste doesn't really seem to bother younger children as much. The idea is that this is really like a moving picture x-ray. So we are watching the food and fluid enter the oral cavity, sometimes because a parent is feeding the child, or if they're able to, the child is feeding themselves. And then that food, because it has barium in it, is highlighted as it moves through that oral phase and down into the pharyngeal phase. So we can get a clear picture of exactly where that food and liquid are going when it passes into the child's pharynx. Sometimes people think about this test as a pass or a fail. So they'll say, she failed her swallow study. And what I would say to you is that any swallow study that you're putting your child through should be about more than a pass and a fail. Much more information, when this test is done properly, much more information can be obtained than simply pass and fail. If a child aspirates, we should be able to use the information that we learned on this test to figure out, okay, well, why are they aspirating? And how can we try to change the way that they're feeding in order to help them not aspirate? That's what this test is designed to do. It's designed for us to make modifications within the testing environment. So for example, offering the child those thickened liquids to see if now they are less likely to have aspiration. So I'm getting the high sign, so I'm going to slide through these next few slides and wrap up. A couple of things that this test is not good for. It does not look at reflux. Doesn't show that. And it's not a good test to look at aspiration of secretions. There's other imaging that looks at both of these things. After your visit to the Leukodystrophy Center for Excellence, after you've seen the speech pathologist, we will often try to help guide you towards whether or not any referrals might be appropriate for your child. You can certainly follow up in the LCE, where you can visit with a speech pathologist again and check in on how the feeding is progressing based on the strategies and recommendations that we've suggested. We also have a full feeding and swallowing center here at CHOP that involves an infant-based program called the Infant Feeding Follow-Up Program. Your child may be appropriate for a video fluoroscopic swallow study, so we would refer you for that. Some children may be appropriate to visit with the airway clinic where ENT doctors are. And then finally, if early intervention or school-based services are appropriate, or a more comprehensive speech and language evaluation is appropriate, we would refer you for that and assist you with setting that appointment up. So I apologize if I've gone a little bit over, but I appreciate it. Yeah, thank you.